All right, let's dive right into this explainer. We're going to completely transform that massive wall of pharmacology data into a highly memorable exam battle plan. If you're a pharmacy student, you know exactly what I'm talking about, right? You're staring at endless lists of drugs, mechanisms, side effects, and it just all blurs together. But today, we're fixing that. We're taking the ultimate high-yield revision guide and turning it into a super clear strategic roadmap. So, are you drowning in 15 different drug classes for your PharmD Viva? Look, if you're cramming for boards or a high-pressure Viva, feeling totally overwhelmed by all of this is completely normal. The source material outlines a staggering 15 different antibacterial classes. We're talking everything from your standard penicillins and cephalosporins all the way to pleuromethylallians and oxazolidinones. It literally feels like drowning in syllables. But we're going to break this bacterial fortress down together. We aren't just memorizing a random list anymore. We're going to deploy specific strike teams. Here's the battle plan for today. First up, our high-yield revision strategy. Then, breaking the cell wall, halting protein synthesis, disrupting DNA and RNA, and we'll wrap up with a rapid toxicity review.
All right, part 1, high-yield revision strategy, the 4 main targets.
So before we even try to memorize names, we really need a mental filing cabinet of vulnerabilities to attack. Think of a bacterium like a heavily fortified factory. You want to shut it down? You can't just throw everything at it randomly. You need to know exactly which critical systems to sabotage. Our source material beautifully groups the top exam tips into 4 primary structural and genetic targets. Notice our front line, the cell wall inhibitors, like beta-lactams and vancomycin. From there, we move inside to the ribosomes with our 30S and 50S inhibitors, completely shutting down protein production. And finally, we've got the DNA and RNA inhibitors, like fluoroquinolones and rifampin, going straight for the genetic code. Whenever you encounter a drug on your exam, your very first step is simply dropping it into one of these 4 buckets. Moving on to part 2, breaking the cell wall, the front line assault. This outermost defense is honestly one of the most heavily tested areas in pharmacology, mostly because these drugs are so universally used in clinical practice. Both of these high-yield drug classes completely stop cell wall synthesis, but they strike different structural vulnerabilities to prevent peptidoglycan cross-linking. Beta-lactams, which include your penicillins, cephalosporins, carbapenems, and monobactams, they specifically bind to penicillin-binding proteins, or PBPs. But glycopeptides like vancomycin and teicoplanin, they take a totally different route. They bind directly to the D-alla-D-alla sequence of the peptidoglycan precursors. The end result is exactly the same, a failed cell wall. But that exact molecular target is what's going to earn you those points on the Viva. Now, these stool mnemonics are going to be your memory anchors. Remember that beta-lactams break the bacterial wall via those PBPs, while vancomycin guards the wall by binding the D-alla-D-alla precursors. I absolutely love these memory aids from their revision guide because they're just so short and punchy. When you hear beta-lactam, think break. When you see a glycopeptide like vancomycin, I want you to picture a literal van parked right in front of the wall, guarding it from being built by sitting directly on those D-alla-D-alla building blocks. Okay, part 3, halting protein synthesis, sabotaging the machinery. Here's the deal. If the bacteria can't synthesize proteins, they simply can't survive, multiply, or cause any damage. But bacterial ribosomes have 2 distinct subunits, the 30S and the 50S. And trust me, your examiners fully expect you to know exactly which drug hits which subunit. The critical exam distinction here is knowing exactly which drugs shut down the smaller 30S subunit, that's your aminoglycosides and tetracyclines, versus the larger 50S subunit, heavy hitters like macrolides, clindamycin, linezolid, and chloramphenicol. Mixing these up is a classic trap on multiple choice questions, so we really need to lock these lists into our memory right now. Let's lock in the memory anchors for the 30S inhibitors first. The word tetra has a T, which helps us link it straight to 30, or 30S. Their main mechanism is preventing the attachment of aminoacyl tRNA. Then we have the aminoglycosides, your gentamicin, tobramycin, amikacin. The mnemonic, all the mycins damage the 30S machine, helps you remember that they bind irreversibly to that 30S subunit, which causes the mRNA to be misread entirely. Now for the 50S side. Use these punchy quotes to remember that macrolides block translocation, while streptogramins synergistically jam up the works. Macrolides like erythromycin and azithromycin bind the 50S and physically stop the ribosome from moving, so that's blocking translocation. Meanwhile, the streptogramins like quinopristin and dalfapristin work together to create a complete ribosome jam. Just keep these simple phrases in your head, and you'll instantly map the drug to the correct 50S subunit and mechanism. Moving right along to part 4, disrupting DNA and RNA, shredding the blueprints. So if stopping the wall and shutting down the protein factories isn't quite enough, we go straight after the genetic blueprints. Notice the contrast here. We're either starving the bacteria of folate to prevent DNA synthesis, or we're directly blasting the existing DNA with free radicals. On one side, we have sulfonamides and trimethoprim. As the guide points out, sulfa starts, trim finishes folate blockade. They sequentially block folic acid synthesis, which the bacteria desperately need to make DNA. On the exact opposite side, nitroamidazoles like metronidazole take a way more aggressive approach. As the mnemonic goes, nitro radicals hit DNA. They produce toxic free radicals that literally cause direct physical damage to the DNA structure. To finish off the genetic targets, anchor your revision with these phrases. You'll quickly recall that fluoroquinolones hit DNA gyrase, while rifampicins shut down the DNA-dependent RNA polymerase. Fluoroquinolones like ciprofloxacin inhibit DNA gyrase and topoisomerase 4. The word twist is absolutely perfect here, because gyrase manages the twisting and supercoiling of the DNA. On the other hand, rifampicins, like rifampin, stop the actual reading of the blueprints. RIF blocks RNA formation by directly inhibiting that DNA-dependent RNA polymerase.
And finally, Part 5, Rapid Toxicity Review, High-Yield Exam Tables.
Listen, you can know all the mechanisms in the world, but if you don't know the adverse effects, you simply aren't passing. Examiners love using these toxicities to build their clinical vignette questions. Recognizing a specific side effect instantly points you to the correct drug class. The target to class alignment is your rapid visual summary to make sure that mental filing cabinet is fully organized. You've got beta-lactams breaking the cell wall, aminoglycosides hitting the 30S, macrolides stopping the 50S from moving, rifamycins blocking RNA. Before you even walk into that exam room, you should be able to recreate this basic grid entirely from memory. It acts as the structural foundation for the specific toxicities we're about to layer on top. Because examiners love testing you on specific signature toxicities. Things like tendon ruptures and metallic tastes are absolute gold. Think about the glycopeptides like vancomycin. If a clinical scenario mentions red man syndrome, boom, you immediately know the answer. Aminoglycosides, they're infamous for dual nephrotoxicity and ototoxicity. If a patient is suddenly experiencing a tendon rupture, your mind should immediately jump straight to fluoroquinolones. And if they complain of a strange metallic taste, that is the classic hallmark of nitroamidazoles like metronidazole. You also definitely want to watch out for these final standout red flags. These are classic exam fodder. Tetracyclines are notorious for causing teeth discoloration and inhibiting bone growth, which is exactly why they have such specific contraindications. Rifamycins will literally turn body fluids, like tears and urine, a bright orange. A crazy detail, but it makes for an incredibly easy exam question if you know it. And sulfonamides are heavily linked to allergic rashes and hypersensitivity reactions. Every single one of these unique toxicities is a potential goldmine for easy points. All right, let's leave you with one final question to really test your newly acquired strategic knowledge. Which specific strike team will you deploy to stop a 50S ribosomal translocation without triggering QT prolongation? Think about it for a second. You know macrolides block 50S translocation, but they also cause QT prolongation. So how do you adapt? Well, the source material gave us the pieces: clindamycin, chloramphenicol, linezolid. By organizing the data into these strike teams and anchoring them with distinct toxicities, you aren't just memorizing anymore. You're thinking like a true clinical strategist. Keep this battle plan fresh in your mind, trust your mental filing cabinet, and you are going to absolutely crush that exam.